Hello and welcome to the Patient Educators Update, where we talk about patient education in a clinical environment. I'm Chuck Jones with Synergy Broadcast, and our guest today is Fran London. Hi, Fran.
Hi, Chuck.
Fran is the patient education specialist at Phoenix Children's Hospital in Phoenix, Arizona, and she is also the author of the book No Time to Teach, the essence of patient and family education for healthcare providers. And Fran's book is normally where we take our topics each week, and periodically we vary from that. And Fran, this week our topic is going to be, I've given it the special title, The Secret to Successful Patient Education Results. I think everybody would like to know what that secret is, don't you?
It would be so easy, yeah.
Yeah. Well, we're going to talk about our secret in just a minute, but there are two bits of research that I would like you to comment on. The first one of these says that patients only understand 50% of what their doctors discuss with them. And I wonder if you could comment on why you think that is, what's going on there.
Oh, a lot of factors contribute to that. First of all, they might not have the basic understanding of biology and medicine in general to even make sense out of whatever the doctor says.
Yeah.
The doctor may be speaking very quickly, maybe using jargon, medical terms that are unfamiliar to the learner, and the patient may be anxious or embarrassed, or, I mean, there are lots of factors, emotional things that go into not being able to hear everything.
Yeah. And, I'll point out there's, I know you know of Helen Osborne. She tells a story about having a shoulder issue. And she was a nurse, went to nursing school and, learned all kinds of good stuff. But when she went to the shoulder guy, she said she didn't understand a word he was talking about. He was talking about things she had no knowledge of, and she really felt dismayed that she was searching for some patient education and she didn't get any. And I think we even tell that story in one of the interviews we did with her. But there's a person who was on the medical side that had trouble with it.
And that's not unusual.
Yeah.
I mean, certainly everybody seems to tend towards specialties lately. So if you're a pediatrics person and you're going for an adult diagnosis, you might not even be familiar with whatever they're talking about, even if you are an expert in your own field.
Yeah, absolutely. Yeah. Okay, now the second factoid I want to mention, 60% of patients do not understand the information that they are given about an upcoming procedure or treatment. So they're going in ignorant and not understanding what they've been told or what they've been given. Many times it's just a pamphlet.
And that's a real concern because we talk about informed consent. And if you're not actually informed, you're not consenting to what you think you're consenting to.
Yeah.
And that's very, very unfortunate. And both of these highlight the need for a teach back in terms of understanding whether or not they do understand. But there are lots of better ways we can explain treatment that we're about to do, a surgery or something, than we generally often do. If you've got a surgeon talking in medical terms about a very complex surgery, the person's going to turn off. If he shows actual pictures of the surgery being done, the person may be grossed out.
Yeah, exactly.
That's where animations are so much more palatable when you're describing what a situation is like that.
Yeah, there's no doubt. And back to something you said a little earlier about informed consent. I remember I wound up in the emergency room last year and was tasked with signing a bunch of papers, and they were going to do some tests, and they said, they're going to do this, and I just signed it. I said, okay, whatever. I had no idea what they were doing, what they were explaining. And my wife was in a bit of a nervous Nelly at the time, and she wasn't going to ask any questions. And later, after discharge, I was asking her questions about this, that, and the other, and she didn't know. And she said, well, I thought you knew. And I said, no, I didn't know. So
that often happens.
Yeah.
And when you're feeling stressed like that, like you've got to get the test done right away, so you have to
Yeah.
sign the paper. You're not going to stop and ask and say, wait a minute,
No.
even if you want to know. And
Yeah.
sometimes you don't want to know. You just want to be done with it and know what the problem is and
Yeah. And
how
have you seen the type size on these forms?
right.
I mean, who can read that?
And they're not simply written. I mean, it's really not clear immediately what it is they're trying to tell you. They
No.
put lots of extra words in.
Yeah, that's correct. Yeah. So it's one of those things that could really be simplified.
Yeah.
Well, okay, so with those two things as a backdrop, what we want to talk about is the secret to successful patient education results. And that is a topic that we have touched on briefly over some of our episodes, but that's basically that a layering or building of knowledge over time. And I'll use a quick analogy. As you know, I'm a weekend photographer and do some sports photography. And part of that is learning how to use a DSLR camera in manual mode. You can't use the automatic exposures and things of that nature. You really have to pay attention to what your subject is, the lighting that you have, and all those other things. And so you have to learn how to use a lot of different functions. And these functions all interact with one another. Things like what's called the ISO and the aperture and the shutter speed, they all interact with one another. So you can't just set them and forget them. They change throughout the day where the lighting changes, if clouds come over, things of that nature. Well, guess what? That stuff is really complicated, and you can't learn it in 5 minutes or 10 minutes, or if you remember the analogy with discharge, 11 minutes.
Right.
I've been at this for months and months and months, and I'm still not to a point where I'm even close to mastery. And so I would compare this to patient education, where the patient comes in for admit and knows nothing or very little. And then by the time they are discharged, they need to know a lot. And if we don't take the approach of layering or building and starting from admission to discharge, if we wait till the last minute, they're still not going to know anymore. So talk to us a little bit about when to start patient education, how to do it, the layering, and how all this stuff can build over time, because at the end, the goal is functional health literacy, meaning I can take care of myself when I get home. So
That's a great analogy you had there, because I think we don't recognize how complex all this is for the patient. Mm-hmm. We've got both the intellectual information, the skills that need to be learned, and the emotional component.
Yeah.
So there's lots going on that they have to manage in order to be discharged and be ready to go home. So we do have to be aware of that and work as a team. I think it's really important to work as an interdisciplinary healthcare team where everyone is involved with every conversation with the patient and the family to find out what they understand, how they understand it, what they need to know, what they're confused about, and to teach very systematically based on what they know and move them forward in a layered way. And every member of the healthcare team has a different way of explaining things from their own point of view.
Yeah.
So getting those lots of different points of view helps the patient see it on lots of different levels, and perhaps one of those is really going to click and help them move forward.
Yeah, because very few of us have one of those memories that we remember everything we see or exposed to right off the bat. And the ability to grab onto little bits in the beginning to create a foundation, and then kind of step that up each time where you build on that. And I think it's really important that the nurse and all the other folks on the care team make sure that they're assessing almost every time they're with the patient and asking them, how do you remember so-and-so? How would you explain this to your husband or your spouse? Can you tell me what you would do if this happens? And get some feedback so that they can kind of, if you think that no knowledge is here and high knowledge is here, and that's admit and discharge, where are they in that continuum of learning, just like the continuum of care, and then respond appropriately? Does that make sense?
Oh, that's great. Another thing to keep in mind, which I think we often forget, is people with chronic illnesses still need to go through this process.
Mm-hmm.
It's easy to assume that someone who's had a disease for 10 or 15 years understands it or knows how to take care of themselves or knows what to do. Not only might they have not learned it well in the beginning, they might have forgotten it, they might have modified it over time. And research changes treatments over time also. So
Yes.
what we are at now may not be what the patient learned 10, 15 years ago. So it's very important to increase this, to do this process, even with people with chronic illnesses.
Yeah, and I would tell you there's one other factor that you didn't mention, and that's the opinions or comments of relatives or peers that interject themselves along the way, where I read this on the internet that says this is not true, that's not true. And so you wind up with misinformation or misconceptions about things that, if you think about it long enough, it becomes your perception of what the reality is, and it's not right.
Right. And that could really interfere with health outcomes.
There's no doubt. There's no doubt, because I have seen that with my own wife, where she will have everything about her diabetes pretty much in check, and then she'll read something or somebody will say something, and then she'll begin to question what she knows, and then she might change the way she's taking her medication because of what she thinks. And you can't do that. And when you question her about it, so-and-so said so-and-so. Well, let's go look that up and make sure, and then get her back on track. And I don't think she's alone in that.
Oh, absolutely not. Everybody does it. Everybody does it.
Yeah. So there's a lot of factors that are fighting the progression of knowledge. So the assessment and the use of teach-back, in addition to the teaching and education, helps, let's say, keep the rudder of the ship straight, so to speak. You may have to zigzag here and there to correct things, but if you're not constantly, checking the wind and checking the seas and things of that nature, you may not go in the direction the patient needs to go, and that's what you have to do. It's not day one you learn this, day two you learn this, day three you learn that.
No, it can't be. It's not a checklist.
Yeah.
It's got to be an interaction, and it's got to be dynamic.
Yeah. Now, one of the things that I can hear viewers thinking right now is, all that's great, but there's 9 other people that are involved in the care team. How do we can't get together and huddle up every day. What do we do? How do we handle that?
Oh, that's documentation.
Mm-hmm.
It makes it real easy. Everybody's got to document anyway. So at least have an education record where you compare your progress, so you can check to see where someone else left off, what they identified as a potential issue that we need to address as a team, and work from there. So you can have communications verbally interspersed if you don't have a regular rounding system where you all talk together. Yeah. But you can also look at the documentation, and that's so important. Yeah. And you have to keep it going.
Yeah, I would agree. And you can also, it's also important to document the tools that you use, videos and whether or not they were set up properly and followed up on, pamphlets or demos, things like that were given, and how the patient responded to those things. Because as an example, let's say before change of shift, a patient is in one of those moments where they ask a question. The nurse says, hey, I've got a great video that answers that. And he or she sets that up for the patient, and they tell him what to look for, to make some notes. The patient watches, well, then there's shift change. And so the nurse, maybe he or she's not back for 2 or 3 days. So whoever is coming on the next shift needs to know that was set up but not followed up on, so they can do that.
That's a great example. Exactly. Yeah.
Okay, very cool. Well, it's a complicated process, lots of things going on, but it can be done. And I think that if we drill down into it, we could all say the absolute secret to successful patient education results is finding a base and building on that, so that everybody's focused on building towards the same goal of the patient knowing how to take care of themselves by the time of discharge. Agree?
Yeah, and I would add that it needs to be patient-centered.
Yeah, yeah. Okay, wonderful. Great information. With that, we'll close out the show. So why don't you tell folks where they can find you online?
I have a website, www.notimetoteach, and I'm on Twitter at @NoTimeToTeach.
Okay, and I would let folks know that your book, No Time to Teach, is available in both paperback and ebook form at Amazon and other book retailers. And if they would like to buy in bulk for in-service, you can go to Fran's publisher, Pritchett and Hull. That's p-h.com, and they'll give you a 40% discount on a bulk purchase that'll save some money. And for those of you that want to integrate video on demand into your patient education process and care plan, please reach out to us at Synergy Broadcast Systems. Our web address is synergybroadcast.com, and our patient education system is called MMDS, or Medical Media Delivery System. So, Fran, thanks so much for your time. Great insights today. As always, we look forward to talking to you next time.
Okay. Bye, Chuck.
Bye-bye.